Well, this is the second of the two videos which I'm putting up regarding pneumococcal conjugate vaccine. The first part of this video, I had put about a week's back. In this, you can get that in this link in this YouTube channel. If you go to this link, it would be better if you view the first video before you view the second part of this second part video. In the first part of this two video series, we have already discussed the points number 1 and point 2. But what we are going to discuss today is there a danger of vaccine serotypes being replaced by non-vaccine serotype antibiotic resistant infections in vaccinated children? You know that pneumococcal has about 90 serotypes. And if you start giving PCV13 and more and more with more and more serotypes, do they get replaced by serotypes which are not there in the vaccine? And more important, is it likely to lead on to increased incidence of antibiotic resistance serotypes? This becomes all the more important because in vaccine manufacture now, there is something called chasing the serotypes. Now what is happening is we had PCV7, then PCV10, then 10 valent PCV and PCV13. So much is available in the market. But I understand that PCV14, PCV15 and PCV20 are already in the pipeline. Therefore, when you keep on increasing the serotypes, the cost keeps on going up. But will not the organism fight back and replace it with other serotypes? Nowadays, we don't have to explain this much because of the COVID. We know very much about replacement of diseases, new serotypes, new genetic types coming, etc. Look at what the Pfizer had to say when they introduced PCV20 in the literature. All the 7 of the new serotypes included in 20-valent pneumococcal vaccine are global causes of IPD, and 6 of the 7 are associated with high fatality rate. In addition, 4 of these serotypes are associated with antibiotic resistance or meningitis. Now, you might wonder, therefore, they talk about what is left out only when they introduce the vaccine which contain these serotypes. Therefore, what one wonders is it a good idea to chase each serotype with more and more, adding more and more serotypes on the pneumococcal vaccine? Want the bacteria fight back by replacing them with more dangerous? Now we will look into this in the next 1 or 2 slides. A series of articles have come in Lancet as well as Lancet Infectious Diseases, from which I am quoting. The articles that come as late as 2019. Some of the facts they said is, I will run through them. Despite the success of PCV, invasive pneumococcal disease remains an important health priority owing to an increase in the incidence of disease caused by non-vaccine serotypes and even known as serotype replacement. Therefore, they are acknowledging that is a problem. But you know, the incidence has gone down, prevalence has gone down very much in the West. But even now, if you look at the total number of pneumococcal disease, serotype replacement is slowly becoming an issue. Serotype replacement has been reported from several countries, but surprisingly not from USA, after the introduction of 13-valent PCV. And the magnitude of increases in non-vaccine serotypes varies from country to country. Therefore, the publications are just coming up. It is surprising that USA has not reported much. Other countries like Israel and all over Europe, there have been multiple reports, and the magnitude of the problem varies. With regard to serotype diversity, the emerging non-vaccine serotypes vary greatly. There's another issue with this. The character of this increased greatly. Of interest, different clusters expressing the same serotype, but different antibiotic resistant profiles are evolving differently. Therefore, the one which we are very much concerned is antibiotic resistance. Now, you will find that in certain countries there is an increase in antibiotic resistance. In certain other countries it is not happening. The same clusters, the same genetic lineages produces antibiotic serotypes which are susceptible as well as certain which are resistant. But they say it has slowly, there is a concern regarding this matter. Now let's spend a minute or two on the mechanism. Two mechanisms of serotype replacement have been suggested. The first is an expansion of non-vaccine type lineages to partly fill the niche vacated by the vaccine type lineages. That means there is a genetic change. That's what I understand. The second is within lineage expansion of the non-vaccine serotypes. That means there's no genetic change, but only thing the serotypes get selectively non-vaccine types get produced, which can be explained by a concomitant increase in non-vaccine serotypes and decrease in vaccine serotypes within a lineage after PCV introduction. Concern of serotype replacement is reflected in WHO's as well as other international organizations recommending a comprehensive surveillance system for pneumococcal disease whenever vaccination is introduced. Now, ideally, the surveillance should be started at least 1 to 2 years before the introduction of PCV and be continued indefinitely for at least 5 years after introduction. This is probably what we might be very much lacking. Most of the developing countries might be lacking, and that is no problem. But you realize one thing, countries without such a system in place should not wait for the introduction of PCV vaccines. The PCV vaccines have such a great effect on the childhood mortality, especially now that a low-cost vaccine is in the market, that you shouldn't wait for the surveillance system to be in place before you start the vaccination program. But a surveillance system is very much recommended. So we answered this question. Is there a danger of vaccine serotypes being replaced by non-vaccine serotype antibiotic resistant infection in vaccinated children? Definitely yes. The answer is yes, but it has not become a major public health problem, and vaccination actually decreases the antibiotic resistance. But if you are replaced by non-vaccine serotype, that problem will issues. Now the next point we are trying to find out is, why is the Indian Academy of Pediatric Advisory Committee on Vaccines and Immunization Practices advise a 3+1 dosage regime when WHO advocates a 2+1 regime for pneumococcal vaccination? Now, what is the best dosage regime in private practice as far as we are concerned? For administration of PCV to infants, WHO recommends a 3-dose schedule administered either as 2 primary doses and 1 booster, or 3 primary doses starting as early as 6 weeks of age. Now, both PCV10 and PCV13 have been shown to be safe and effective and to have both direct and indirect effects against pneumococcal disease caused by vaccine serotypes when used in a 3-dose schedule, as already discussed, or in a 4-dose schedule, that is 3 primary and 1 booster dose. Both these are safe and effective. If a 3-dose primary series is used, the first dose may be given as early as 6 weeks of age with a minimum of 4 weeks between doses, that is 6, 10, and 14 weeks. That's what we do normally. Now, if a 2+2 primary or 1 schedule is used, the first dose may be given as early as 6 weeks of age, preferably with an 8-week interval between the 2 primary doses, and a booster dose administered after between 9 months to 15 months. Therefore, whenever 2 primary doses are used, the minimum interval should be 8 weeks. I don't understand why in COVID vaccine this has not been followed. Anyway, that is a different matter. Therefore, when you use 2 primary plus 1, it is 6 weeks, 14 weeks, and preferably we try to give it with at 9 months the booster dose. In the 2 primary and 1 booster dose, 2+1 schedule, for certain serotypes 6B and 23F, the antibody level in the interval between the 2 primary doses and the booster dose may be lower than when 3 primary doses are given. But following the booster dose, the antibody level may exceed the following 3P schedule. Now, the 2P1 schedule may leave some infants incompletely protected during the interval between the primary series and the booster, that is between 6 months and 12 months, or between 6 months and 9 months if you are giving the booster at 9 months. It may leave the children vulnerable, especially to 6B and 23F. But it may confer some advantage in terms of protection against serotype that cause slightly later disease in later life, like serotype 1, and in the duration of protection in comparison to schedules without a booster dose. Therefore, what it essentially says is that if you just give 6 and 14 weeks and don't give a third dose, the antibody levels are not optimal, especially for 6B and 23F. But once you give the booster, it becomes enough. Now, in this article on the effectiveness of 7-valent and 13-valent pneumococcal conjugate vaccine in England, they studied a cohort study from 2006 to 2018, published recently in the Vaccine 2019. This was actually not about the schedule. That was the schedule which is followed by UK during the time. In June 2020, they changed it anyway. Now, what they found is PCV are highly effective. They're analyzing PCV13, highly effective in preventing vaccine serotype IPD, except for serotype 3. This is well known. Serotype 3 doesn't reach statistical effect in most of the studies. But what is surprising is they have also said serotype 19A, invasive pneumococcal disease, has also persisted, likely due to the slightly lower vaccine efficiency or more rapid waning of protection. And now this has been propagated by Synflorix by telling even PCV13 is not effective against 19A. But is the odd study out, and also this is a 2+1 schedule. Therefore, in most of the Western countries, they're using 3+1 schedule, and I mean, at least in the United States, they're using 3+1 schedule. If you look through the European ones, the schedules are quite variable, and UK has now gone to only 2-dose schedule now. For whatever it is, there is a study which shows PCV13, there is a waning of immunity, faster and lower vaccine efficiency probably when used in this schedule. Now, if you look back at the 3+0 schedule, it consists of 3 primary doses with no booster. However, limitation of the shortened schedule for countries with a significant burden of disease was type 1 is that the extended period of susceptibility to serotype 1 and the invasive nature of that serotype may require prolonged levels of antibody in the second year of life, especially after 18 months of age. Therefore, this is again, they are reiterating the fact that in the second year also, you require protection 6 months to 9 months, you require protection in the second year. If you give 3+10 schedule, you will find that the child is not adequately protected in the second year of life. If you give 2+1 schedule, the interval between the primary and the secondary dose, 6 to 9 months or 6 to 12 months, again, the child may not be adequately supported. India is introducing, whenever they have taken up some districts, they have already introduced PCV13, 2+1 schedule with 2 primary doses at 6 and 14 weeks, followed by a booster dose at 9 months. Now, remember that India is going to roll out, as per 2021 budget, it has been budgeted to roll out the pneumococcal vaccine all over the country. Therefore, the gold standard of regime for dosage regime for pneumococcal vaccine is 3+1, 6, 10, 14 weeks, and a booster at around about 18 months. And this has been defined by US licensure trials also. And in Western countries, they give the dose in infancy generally 2 months apart, 2, 4, and 6 months, while India, we are giving 6, 10, and 14 weeks. And this is what is advised by the ACVIP committee also in 2021. The ACVIP committee of the Indian Academy of Pediatrics is very vehement in making a solid statement by telling one should refrain from using 2+1 schedule for individual in office practice, and that can be used only in national immunization program. Yes, we have told the theoretical reasons behind this, and I think the committee is right. But you must understand that the 2+1 schedule and the 3+0 schedule are both recommended by WHO, and the 3+0 schedule is also approved by the Drugs Controller of Government of India. Therefore, if you want to save cost, and you can generally cut down on the pneumococcal vaccine, because cost is a major factor. Not all the Western countries are giving 3+1. USA is giving 3+1 schedule. But on the whole, I would say that ACVIP committee is right in making this a very important statement. But individual pediatricians need not worry if they give 2+1 or 3+0 schedule. They are fully backed by literature as well as the legal sanctions as far as India goes. Having said that, you will be surprised to see what the NHS has to say, because as far as NHS immunization schedule, I was really shocked to see that they give only 2 doses of Prevnar. One when the child is 12 weeks old, 3 months, and the other when they are 1-year-old child. I checked, double checked, and triple checked. That's correct. Previously, they were giving 3 doses. Now they are giving only 2 doses. The reason they are telling is that the pneumococcal infections in UK has become so low that 2 doses are enough after doing appropriate surveillance. Cost is a major factor, even for developed countries. As far as pneumococcal vaccine goes, I think probably Brexit also contributed to this. Now, for children whom you have, they have not been vaccinated at the required time at 6, 10, and 14 weeks, should continue. Even if they come to you with a pneumococcal pneumonia, you should complete the immunization. That is something which many people miss out. Now, between up to 6 months, it's the same dosage regime. That is 3 doses, 3+1. But 7 to 11 months, you give only 2 doses. That is 4 weeks apart, 8 weeks apart. Both PCV10 and PCV13, that is what is given. And 1 dose is booster is given in the 2nd year of life. Therefore, below 1 year, if they come, up to 6 months, you give 3+1. 6 months to 12 months, or up to 1 year, you give 2 doses plus 1. It's not 3+1, 2+1. And between the 2 doses, you give 8 weeks apart. And 12 to 23 months, that is in the 2nd year of life, you give only 2 doses 8 weeks apart. You don't give a booster dose. This is both for PCV10 and PCV13. Once above 2 years, PCV13 requires only 1 dose, while PCV10 requires 2 doses 8 weeks apart. Therefore, there are slight differences in this. Now, you may ask, what's the dose regime for pneumococcal? You must understand, for 10-valent PCV, there is no studies about 2 years. Therefore, it is, if you are using it, it will be an off-label use. And to use it in any regime other than 2+1, as I already mentioned, may also be an off-label use. But still, I don't find any reason why you cannot use it below 2 years, or probably even about 2 years. Therefore, we have finished our discussions on what is the best dosage regime in private practice in India, and we have agreed on 3+1 dose being the best for reasons we have fully explained. But please understand that the WHO's 2+1 regime, as well as the 3+0, which is approved by DCGI, the Drug Controller of Government of India, can also be given, but they have a slight disadvantage, as already we have mentioned. Finally, we go into a million-dollar question: which among the 3 pneumococcal vaccines available in the market one should choose for the vaccination in private practice in India? That we will see in the coming slides. My talk will mainly concentrate on the PCV vaccine choice in private practice. Now, regarding the choice for the country, I think it is very obvious. The Pneumococcal would be the choice because it's made in India. It contains 6A and 19A, and action should be very easy. The choice should not be difficult. But in private immunization, once a PCV vaccination has been initiated, product switching is not recommended. Some basic principles I'm running through. If a series cannot be completed with the same type of vaccine, the available PCV product should be used. Now, this is important because when you see a patient and he chooses a very costly vaccination, you should make it clear to him that he has to take 3 more doses of that PCV. And it is not good to change midway the brand. But if you have to give some other brand, then restarting a series is not recommended even for the primary series. These things, I suppose, are well known to everybody. Actually, there is difficult to do head-to-head trials of either vaccine, but to see whether there's a clear advantage over the other. Now, this is what adds confusion together. The PCV10 manufactured by GSK and PCV13 manufactured by Pfizer are two giants in the pharmaceutical industry. Both of them come with their own evidence and showing their own presentations to the pediatricians, making them confused as to which vaccine to choose. Each have their own arguments in their favor. Now, because there is no head-to-head trials and it's difficult, I'll come into that slowly. I'll try to make some things clear here. But you cannot see, though based on recent pneumococcal serotype surveillance studies from different parts of the country, PCV13 definitely has some edge over PCV10. What the surveillance study shows is that 19A is a very important problem. PCV13 when compared to PCV10, PCV3 you can ignore because it doesn't have much effect. PCV6A, probably 6F has some cross protection. And regarding PCV19A, PCV10 doesn't contain 19A but 19F. And the GSK would like you to believe that there is cross protection. But definitely this cross protection, especially for 19A, which is a very invasive serotype and also antibiotic resistance in many parts of the world, and which is considered to be between 3 to 8% existence in India, is a matter which shows that PCV13 definitely has an edge. Now, this will be very severely contested, as I will show. There are multiple publications comparing PCV10 and PCV13 effectiveness. Now, Pneumococcal is a new one, 10-valent PCV is a new one, therefore there is not much of debate regarding this, not much of publications. One which is often quoted is the Cereva study, recent ones. I am only just going to point out to you 2 recent ones, published in Lancet in 2020, therefore I'm bringing you very well. And the comment of it came in March 2021. I'm talking in February 2021. Therefore, this comment came before the print in the online, probably in the online version. Therefore, though I am quite up to date regarding my presentations. Now, you see how the confusion comes here. Now, I'll read out what their conclusion is. The magnitude of change varied across countries. Given the variation found, the surveillance program design and difference in immunization program in participating countries. Now, leave this jargon. What they concluded is no conclusion can be made from these data on whether these program using PCV13 provided more benefit than program using PCV10. Now remember, this is a very big study. Actually, this was an observational study, retrospective observational study, over 12 years in 10 countries, including Latin America and Caribbean. And they looked at the sera of 1,200 samples. That was a huge study, though it's an observation study. Now, if you look at it, I'm sure GSK will jump in glee because they have said that there's no conclusion can be made from these data on whether the program PCV13 provided more benefit than PCV10. Hold on, the next conclusion is the increased amount of serotype 19A in isolates in countries with PCV10 vaccination is perturbing because of the increased penicillin resistance. Now, what happens is definitely there is an increase in the 19A. Probably it doesn't obtain statistical significance when you do a total study like this. And this is definitely of concern when we give private immunization, because we like to give the best to the patient. Therefore, when you counsel, you will have to tell that. But the cost involved is also very much there. Therefore, now there are many studies which come to this conclusion, that there is no data there to show that there's one PCV13 is superior to PCV10. Individually with glowing signs, one might definitely will have to say PCV13 has an edge. And this is acknowledged by this study also. This shows that there is an increase in the incidence of increase in the isolation of 019A, and it has increased penicillin resistance. I hope I made the matter clear. One recent head-to-head study, which has been published again in Lancet, and the publication came in 2019. And this is considered a head-to-head study between PCV10 and PCV13 in a developing country in Vietnam. You know what happened here? They looked at the antibody level in a dose given 2+1 regime. And I find that for 6A and 19A, PCV13 had significantly higher antibody levels when compared to PCV10. But when coming to a conclusion, they showed that it's in all other the levels, I mean the anti-levels of the other, which the antigens were common to both PCV10 and PCV13. Understandably, there was not much of difference. They came to the conclusion of non-inferiority of PCV10 versus PCV13 in terms of immunogenicity against invasive pneumococcal disease. And they come to the conclusion that provides important endorsement of the existing WHO advice on the use of PCV for infant immunization. Therefore, WHO keeping both of this in the same plane, they say this study gives support for them. I'm a little surprised at this, because the immunoglobulin antibody levels for 19A and 6A were significantly lower in PCV10 when compared to PCV13. They just make a statement that higher level, statistically higher level of these two antibodies, whether it has an effect on the significance of it is not known. I don't understand how the significance cannot be known. Therefore, I just want to tell you that by head-to-head studies are rare, and from this you cannot come into a real conclusion. And the WHO has a tendency to place both PCV10 and PCV13 in the same level of efficacy. Now, if you go into a pure scientific evidence, and the fact that 19A is a very common invasive disease and 19F does not produce cross protection to the level needed, definitely PCV13 has an edge. When there's no much of head-to-head controlled studies, it is worth looking at the experience of countries over the last 10 years, because it's over 10 years since both PCV10 and PCV13, Synflorix and Prevnar has been in the market. Pneumococcal is of course a new entry, and there's not much experience with any country. Now, one thing which is often talked about is the Belgian study experience. Now, what happened here is, in Belgium, PCV13 replaced PCV7 in 2011. 4 years later, in July of 2015, PCV10 replaced PCV13 in the northern part of the country. In the southern part, the switch was in mid-2016. Therefore, they went from PCV13 to PCV10 gradually over a period of 5 years. The change was a result of equally effective rating of PCV10 and PCV13 by the National Immunization Technical Advisory Group. Therefore, only economic factors contributed to the decision. Now, you cannot just ignore the fact that PCV13 is almost in India right now where I work, it is charged 4,900 rupees. By PCV10 is 2,300. It almost comes to double. And Pneumococcal is given as 1,900. Therefore, cost is a very major factor. Even rich countries have to take this into consideration when they are equally effective. That let's go back into PCV10. In 2 years, they found a substantial increase in pneumococcal disease, mainly due to 19A strain, and Belgians referred back to PCV13 vaccination. This Belgian experience of emergence of non-covered serotype after switching to a lower valent PCV is considered very important for policymakers considering modification to childhood vaccine strategies. Therefore, this is a factor which is very much favoring PCV13, and this Belgium experience would be narrated to you by, especially from the Pfizer group. But there is always a counter to this. Now, the beauty of science is that there is a counter to any argument. Now, the drawback of this inference is that this study is based on the assessment of a single year typing data rather than a multi-year assessment with thorough epidemiological analysis, which is deemed crucial for assessing the success of vaccine programs as emphasized by public health experts. Now, this counter is made by GSK, which produces Synflorix. But you must understand no country can wait for 5 years before they change their bad decision. Therefore, I think the Belgium experience to a certain extent shows in countries in which there is 19A, PCV13 is the vaccine of choice. But again, there are other factors. Other countries and regions have switched from PCV13 to PCV10, including New Zealand, Morocco, El Salvador, Quebec, and some regions in Sweden. I think Sweden is the only country which uses PCV13 in certain regions and PCV10 in other regions, and Italy. Data from Casablanca, Morocco revealed a significant reduction in the number of invasive pneumococcal disease isolates due to serotypes contained in PCV13 and PCV10 in children younger than 2 years. Now, the only reason why they switch over to PCV10 is because of the cost. Remember that. As far as efficacy is concerned, PCV13 has an edge. Another place where we can look for experience is Quebec, Canada. Quebec is French-speaking Canada. Since 2011, PCV13 has been the vaccine used under Quebec immunization program. However, following recommendation made by an expert committee, PCV13 was replaced by PCV10 in May 2018. Now, if you go to the website and read it, it's interesting to follow it. In Canada, Quebec is the only province where PCV10 vaccine is now being used. But there in the website they have written there is no studies confirming that Synflorix is effective for certain groups of people. The Prevnar vaccine is still recommended for children, for people 5 to 17 years at risk for serious pneumococcal infection due to medical condition, adult with an absent or dysfunctional spleen due to surgery or certain diseases, and those with a weakened immune system. Therefore, they acknowledge the fact that if you want more effect, you better go in for Prevnar 13. Therefore, in countries which use PCV10 like Quebec, in high-risk population, they continue to use PCV13. Therefore, they are endorsing that the only reason they use PCV10 for the general population is of the lower cost. I am, as a pediatric practitioner for the last 35 years, I feel that each one of us should have a default vaccination schedule. Actually, a vaccination schedule should be uniform as much as possible so that it does not confuse the patients. But unfortunately, in India, where the people have to pay for their vaccination in private practice, and many of the vaccines are very costly, I think that you cannot have a single bullet to heal all the problems of immunization. Now, I have a vaccination schedule as a default, but I don't impose it upon the patients. I give them the choice after explanation. Now, you may not select what I do, and I also differ from the ACVIP committee recommendations in many aspects. I will tell you as I go along. Now, first of all, at 6 weeks, I've tried to give Pentovac, IPV, Pneumocil, and Rotacil. I am using the trade name. The Pentovac is a vaccine which contains whole cell. Therefore, I am using a whole cell pertussis vaccine because I do feel strongly and I am convinced that whole cell vaccine have a longer immunity, and the only reason the Western countries are using SLR vaccine is because they can't go back on the whole cell vaccine. There is an epidemic in the Western countries due to pertussis in adolescents, producing high rate of neonatal whooping cough also, which we cannot afford to have in India. Therefore, I do feel that in private practice also, whole cell vaccine should be used. Now coming to PCV, which is what now this regarding nowadays standalone IPV is available in India, and I think that is that medication of choice, the vaccine of choice, and not OPV. Now here the 10 weeks I do give Cortravax, and here I think no hepatitis B vaccine is given by me. Again, I differ from the ACVIP committee recommendation, which gives 0, 6, 10, and 14 weeks. But you know, the best dose regime for hepatitis B is 0, 6 weeks, and 6 months. And I feel that it should be religiously followed because we are not giving a booster for hepatitis B vaccine. That is all the studies of hepatitis B vaccine has been done by 0, 6, and 6 month regime. And you should not tickle that or do any change the regime because we are not giving a booster even at 1.5 years. Therefore, that is something again I am differing from the ACVIP committee. You may or may not agree with it, and therefore you have to give Cortravax or EC4, which contains whole cell vaccine as well as HIP vaccine. Now, at 14 weeks, you give Pentovac, IPV, and Pneumococcal and Otacil. Now, this is the regime which, therefore, I am preferring Pneumococcal, and I have already explained the reason for it, but I put 2 slides back to enforce what it is. Now, there might be some advantages of this is because I am using Pneumococcal, it is cost effective. On the other hand, I am also using Pentovac, which is much less costly than AP containing SLR containing pertussis vaccines. Therefore, the cost is very much saved by this, and also mind you, it is more effective than giving SLR combined hexavalent vaccine like Infantrix or Hexacin. This I totally differ from the ACVIP committee regarding this. I feel this default immunization schedule which I have proposed is less costly and more effective. But there are problems. There are 3 injections in this. Therefore, many mothers may not like. You will have to give Pentovac, you have to give IPV, and you have to give Pneumococcal. Therefore, 3 injections is not something people like, and Pentovac definitely is slightly more painful than SLR vaccine. And the other problem is I am giving IPV for all the 3 doses because I feel that it is a superior. I cannot discuss the full details of it here, but I do feel that IPV is superior, and that's what the ACVIP committee also says. Some pediatricians do give OPV along with the IPV because they say that WHO is not happy if you don't give OPV. But I don't think it is proper for us to give double dose of a polio vaccination every time the patient comes to you. Therefore, this would be my immunization schedule for 6, 10, and 14 weeks. That's where the real issue comes. And I'm giving a 3+1 regime for Pneumococcal. Now, I want to emphasize 2 things. Normally, I never put a slide twice in the presentation. I had put this slide before. You might wonder, how can you choose Pneumococcal when it does not contain 4 and 18C? Now, the argument for it, which is that all the studies done in South America and India show the prevalence of these strains to be very low. That is the argument in favor of Pneumococcal. Synflorix contains these vaccine, and I'm sure GSK is going to contest this very much. And if I may turn into a GSK spokesman for one slide, look at this article published by the Infectious Disease Microbiology and Parasitology. It's an international microbiology article, and this is a review article. And the topic is clinical implications of pneumococcal serotype invasive disease, potential clinical presentation, and antibiotic resistance. Now they have reviewed 8 well-known international studies, and among them they have classified highly invasive serotypes statistically significant. They have also classified the strains into a highly invasive, statistically insignificant, less invasive, statistically insignificant, and less invasive, statistically significant. Now, in the 6 of the 18 studies, you would find 4 and 18C coming into place. Therefore, internationally, 4 and 18C are highly invasive serotypes, statistically significant. Now, therefore, you just cannot brush under the carpet that pneumococcal does not contain these highly important serotypes. And Synflorix contains 4 and 18C. Therefore, when it comes to head-to-head comparison with pneumococcal, we might be fully justified in the national program to use pneumococcal because it's cost effective and internationally accepted also. Now, what do you do in private practice? Probably, if you look at head-to-head Synflorix with pneumococcal, Synflorix is about 300 rupees more costly than pneumococcal in my hospital. It should have been, the pneumococcal should have been much more cheaper, but it is not. But the fact of the matter is, Synflorix is a vaccine which is there for 10 years, used in 40 or 50 countries internationally. Data much more there than pneumococcal. All these are there. Therefore, which do you use in your private practice? But I would still stick my head out and use pneumococcal because, at least for the time being, because internationally I have found most of the international authors are quite excited about pneumococcal and don't seem to be very much concerned about its absence of serotype number 4 and 18C. There's no doubt that it needs surveillance, and we will have to keep a close look at the evolution of pneumococcal infections in India. Now, even this vaccine, which I said the schedule which does not contain AP vaccine is actually cost saving. But even this, some patients may find it a little too costly. Can you make any more adjustments? Now, this is one which I would just tell you. You instead of giving IPV, you are fully justified in giving OPV at 6 and 10 weeks. Now, if you give OPV at 6 and 10 weeks and then give a single dose of IPV, this is fully endorsed by the WHO. Therefore, at least one dose of IPV, that's what they say. Now, fractional dose of IPV are not available in the private as where I practice. That's one way of saving vaccine. The other way is, along with that, instead of giving 3+1 dose, you can give 2+1 pneumococcal. First 6 weeks, and then at 14 weeks, giving 8 weeks apart, and you can give a booster at 9 months. Remember that a country like UK gives only 2 doses, total 2 doses of pneumococcal vaccine. Therefore, that's the ways in which you can save the cost. Now, 2+1 regime. Therefore, there will be no PCV at 10 weeks, only one IPV. Now, never. Now, if the patient says, so sorry, doctor, I can't afford your PCV, it is costing 1,900 rupees. I don't want that. I do not skip PCV and give primary immunization. I found many pediatricians just give the primary immunization without PCV, telling that the patient cannot afford it. If they cannot afford it, I think now that India is rolling out, but it has been budgeted in 2021 to roll out PCV vaccine all over India, and hopefully all the government hospitals would start giving pneumococcal vaccine. It will be unethical in private sector, as some pediatricians are doing even now, to skip giving PCV. Never do that, because pneumococcal vaccine has got a tremendous effect on childhood mortality. For some patients, cost may not be a consideration and they would like to have the best vaccines. Now, for them, the only difference I would like to say is I would definitely try to give PCV13 Prevnar, but I will still hold on to giving wholesale vaccine Pentovac. Now, why Prevnar? Because the reasons I have already mentioned, and also the fact that data are available for 10 years and it is one of the most time-tested vaccines all over the world, especially in USA. It contains 6A and 19A also. So you give Prevnar at uh, 6 weeks, 10 weeks, 14 weeks, and then a booster at 1.5 years instead of Pneumococcal. But you should make the patient fully aware of the cost and the implications that is involved. I'll give you a taste of the cost of these immunization. First, I will go back to Pentovac, which I am giving, which then we will go back to Prevnar. Now, when you give Pentovac, this costs 450 rupees, and you will have to give injectable polio because this does not contain polio. Therefore, these together will come to 950 rupees. While Infantrix will give you 2,850 and Hexaxim is 3,900. Therefore, if you are giving a wholesale vaccine, you are saving somewhere between 1,900 to 2,900 per dose. Mind you, you have to give four such doses, and you can find out that the saving is somewhere between 8,000 to 12,000 rupees. This you'll have to make it. This is a very important thing which you'll have to take into consideration. But of course, also realize fully well that wholesale vaccine is superior to ASL vaccine. Now coming back to Prevnar, the Prevnar costs 3,800. When the patient says that I want the best, make him aware that is almost double the other vaccine. Synflorix is 2,200 in some hospitals where I work, and 1,900 is Pneumococcal. Now the difference between Pneumococcal and Synflorix is only 300 rupees. It should have been much more. I don't know why it is not. Now you save it somewhere between 1,600 to 1,900 dose, or you are giving additional somewhere between 1,600 to 1,900 per dose when you are giving Prevnar. This you have to make it very clear to the patient when he comes on the first dose if he chooses this vaccine, because he has to take 3 other vaccines. And it is not proper that he comes a second time and says, doctor, I can't afford this time, please change over. Tell him that will not be a good idea, because you are not supposed to change the brand midway. But of course, if he comes back and he insists, it's better than not giving the vaccines, better to change the brand. Now there's a fourth group of patients who insist on having a painless or less injections. Therefore, they are not happy with 3 injections, or they have heard about painless injection and they insist on it. For these patients, I might give Infantrix XR, which is definitely less painful. And it avoids IPV vaccine also because it contains IPV. Therefore, instead of 3, you're giving only 2 injections. And at the age of 10 weeks, I try to give Pentaxim is available because it doesn't contain hepatitis B and it is not required at 10 weeks. And I try to give at 14 weeks Infantrix XR or Hexaxim. These are the 2 vaccines which is available in the market. But I am a person who keeps telling them that, of course, there's an advantage. It's less painful. It contains only 2 injections, this regime. But I tell them less pain, less gains. Definitely giving SLR vaccine, the longevity of the protection is less. There's no doubt about it. Some points in regarding 6, 9, and 12 months. Now, because I give 0, 6, and 6 months regime, very particular hepatitis B, I give it 6 months. And I'm not going to talk about the other vaccination which are advised at that time. Now, 9 months is the time of MR vaccine. And I would, if you are giving 2+1 regime PCV, then you would give Pneumococcal at 9 months. And the rest of the vaccination, I'm not going to talk about it. Now, regarding this, remember that hepatitis B are given at the first 4 weeks. That is 6, 10, and 14 weeks and 0. 4 doses are given by hepatitis B by ACVIP. That is at birth, 6, 10, and 14 weeks, while I try to be more scientific by giving 0, 6, and 6 months of life. The reasons which I have already stated before. Regarding the booster dose above 1 year, I tend to give it at 15 months. With this, we come to the end of the presentation. And this is my YouTube channel where I put you can find the other videos on pediatrics which I have put. And this is the pediatric, this is the blogs. If you want to read the blogs which are written about pediatrics, you can find it. Two particular things which I was banging you about during the immunization schedule is, one, I am using whole cell vaccine. The exact reason I have explained fully in a blog in this particular link. And I also deferred in the hepatitis B schedule. The exact reason for this I have explained in full in this particular blog. That if you have any doubt, both of this, both the using of the whole cell vaccine instead of the SLR vaccine, as well as pertussis is concerned, and the justification for using 0, 6, and 6 months using for hepatitis B, which I have deferred from the ACVIP committee recommendation. I give the full explanation. I given the full explanation in these blogs. Therefore, I hope this was useful to you, and thank you for listening to me so long.